In episode 2 of Walk and Talk Improvement, we're focusing on enabling and empowering staff. You'll hear about staff engagement, how healthcare services help people connect with and through their work. And from these conversations, you'll find out more as to what staff engagement means through 5 healthcare colleagues. I'm Mary Browne. I'm a public health doctor working within the National Quality and Patient Safety Directorate for the last 10 years.
And I'm John Fitzsimons. I'm a paediatrician with Children's Health Ireland at Temple Street, and I also work in the National Quality and Patient Safety Directorate. In this podcast episode, you'll hear real-world examples of what staff engagement means from people who do it every day. We hear from leaders on the value of staff engagement and how and why they support it. And it isn't only leaders who are using staff engagement. Colleagues within teams are using it to provide peer-to-peer support.
So John, if our topic is engagement, let's start with a very engaging contributor, Caroline Lennon-Nally. Caroline works in the National Quality and Patient Safety Directorate and has always championed staff engagement throughout her career. I met with Caroline and asked her what staff engagement means to her.
Staff engagement, I suppose, as a starting point, is the greatest indicator of organisational performance. And evidence would show that good staff engagement can result in so many different things, from lower patient mortality right down to a reduction in financial waste, improved patient experience, reduction in the number of incidents, improved clinical care, lower absenteeism, improved staff retention. But that's kind of, I suppose, an outcome of staff engagement. I remember back in 2017, as one of the members of the National Staff Engagement Forum, the forum defined staff engagement as staff are engaged when they feel valued, are emotionally connected, fully involved, enthusiastic and committed to providing a good service, and when each person knows that what they do and say makes a difference. And that actually came from members of the Staff Engagement Forum themselves.
Can you share with us what that looks like and what it feels like?
Again, in my experience, Mary, it's always about seeing the person. So, particularly when we work in a large organisation, our role or our grade or how we're kind of perceived within that organisation, that can be quite influential. Whereas I think if we can drop that and we actually see the person behind the grade, behind the role, and we engage with that person rather than with the title or, whatever else kind of that goes with their role or their job description. And we start to relate to people on that level, where there's respect and it's a mutual respect, I think is so very important. When you ask me, Mary, for an example of, say, senior people in our organisation, I remember on one occasion, the person who was head of HR nationally, I had never really known somebody at that level in the organisation before. I would have known their name and I would have recognised their photos, but I never really would have engaged with them. And I remember a number of years back, again through the National Staff Engagement Forum, we decided to record a song, and we were meeting over in Connolly Hospital, and we were meeting actually on a Sunday. And I remember driving across one day, and it was actually snowing the same afternoon. And I kind of thought I must be mad to be out on a Sunday afternoon going over to record a song for the health services choir. But I was doing it because basically I knew that the person, the senior person who was organising it would be there and had driven a significant distance in order to be there. And when we arrived, there was some food for everybody because people had come from like the four corners of the country, really. There was no payment involved. Again, that discretionary effort. People were there because they wanted to be there. But the sense of goodwill that was developed as a result of that initiative, and, I met people from Clonmel, from Cork, from different regions around the country that to this day I would feel I could actually pick up the phone and I could look for a piece of information about anything that I needed work related. as a result of those connections. So for me, that's kind of people who are senior in the organisation, I think, can really lead by example in those situations.
What stands out for me there was the visibility of that senior leader and their commitment to supporting an initiative that was important to enable staff to come together and to connect. So certainly as a feature, or what senior leaders can do to support a culture of staff engagement, visibility and presence seem to be two important features.
They are, and I'd add another one to that, Mary. I think approachability is very important, because if you are, maybe you have kind of a lower role in the organisation, you need to feel basically that the person you're going to maybe step up and ask something of, that they are approachable. So I think how we are in the world, whether we're approachable or not, also kind of determines the level of staff engagement.
That's lovely, Caroline. So the three features there that through your stories and sharing your experience that have come out and that stand out for me are visibility, being present, and being approachable.
Yeah, and for me, I suppose that whole piece around our humanity, the importance of being connected to our own humanity, because I think if we do that, there's a much greater chance that we'll be able to connect to somebody else if we're connected to ourselves.
Caroline Lennon-Nally, who shared some lovely perspectives with us on humanity and staff engagement. Next, Elaine Fallon, who is the Staff Engagement Lead for Sale to Hospital Group. Elaine has been doing great work with her colleagues on setting up local staff engagement forums to support meaningful engagement across the group. Elaine began her conversation with Mary by firstly sharing what staff engagement means to her.
For me, Mary, it's always been about how we value our staff, involving them in all the decisions that we make on a daily basis in relation to how we want to deliver our services and deliver our care. But it's also about showing how we listen, because our staff are the ones very often on the ground. They know exactly what the problems are. They know what needs to happen to make positive change. So sometimes rather than, having managers sort of sitting up here away from the problem, actually come down to where everything is going on the front line and really make a point of actively listening to our staff. So that's what it means to me, and that's what it's always meant to me. And way back in 2010, before we'd ever even heard of staff engagement in Ireland, I was very interested, even back then, Mary, about wanting to do something to make a difference, and was very fortunate when I was doing my Masters in Leadership, Quality and Management Development to be able to do my thesis on staff engagement. So it really opened up my eyes as well.
Elaine, you've mentioned there some reasons as to why it is so important. Could you expand a little bit more on that for me?
I think, when we think about healthcare, a huge amount of resources have been put into how we are with our patient services, patient and family engagement. And we could say, well, quite rightly so, that's why we go into healthcare, because we want to look after people and give them the best quality care that they deserve. But I think for me, Mary, there are two sides of the same coin. If we're looking to get really good, effective patient and family engagement and deliver that quality, compassionate, safe care, then the other side of the coin is we have to have really good, effective staff engagement. You can't have one without the other.
Thinking back over that time and before you started your current role, Elaine, what have been some of your experience of staff engagement?
I suppose for me, I was very aware of the National Staff Engagement Forum that, did a huge amount of work in relation to how we actually link in all of the different areas where we offer healthcare. So not just all of our acute hospitals, but even the voluntary hospitals, our mental health services, our intellectual disability services, all of it. So I was very aware of that. And in 2016, we came up with a fantastic definition of what staff engagement is. But the other side of that, Mary, and a little bit of a concern for me, was at times there were some people that just didn't really understand the concept of staff engagement and didn't really get how important it is. You know, when we think about what it is that we want to deliver, the staff engagement piece was slightly disjointed. And that was something that I was very aware of, you know, as I was on my own journey in relation to staff engagement.
If I was to walk into SAILT, or if anybody was to walk into any of the hospitals within the SAILT Hospital group, what would staff engagement look like, or how would that person feel that staff engagement was something that was important within that hospital?
Okay, so in some of our hospitals, not all, because it's a work in progress, we have what are called staff engagement forums. So these are very much led by the general manager along with their human resource manager colleagues. And then they actually look to get staff representatives from each of the different staff groups. And then one of those staff representatives actually chairs the staff engagement forum, and it's a rotating chair. And what those forums do, Mary, they do a lot of work in relation to actually being able to get into the issues with staff on the ground. So whatever the issues are for staff, whatever they feel that they really need, they can bring to the representative that's on the staff engagement forum. And those issues are then discussed, and they actually put forward very robust action plans so that what it is that staff are saying that they need, that they can actually get in a formal way. And I think I was just sharing with you in relation to Dr. Kate Granger, and the reason why her work was so important. She started off this whole initiative, Hello, what's my name? Or Hello, my name is. And, you know, the piece of research that was associated with that was so interesting because a cohort of elderly patients and a cohort of paediatric patients were asked the same question. What is it that you need most when you come into hospital? And then they also asked the doctors and the nurses that were looking after them. So the doctors shared things like they want a quick diagnosis, they want a very robust treatment plan, they want a good discharge plan to get them back out either into the community or back home to their families. Nurses shared things like they expect us to be professionally competent in our role and to be able to deliver really good quality but compassionate, safe care. When they asked the elderly patients, they came back with, we just want them to tell us what their name is. And when they asked the children said, we just want them to smile. You see, so it's interesting sometimes what people think other groups of people need. So in this case, it was these two different cohorts of patients. What doctors and nurses felt they needed was very different to what they themselves came up with. And so I've used this same analogy when I've been talking to senior managers within the organisations. And that's why it's so important to ask your staff what it is that they need rather than assuming what it is that they need. It was a beautiful piece of work that she did, and there's so much that we can take from that. So in SAILTA, that's what we do. We're trying very hard now to put our staff first and to actually ask them, what is it that you need? And then working with them.
I loved those sage words from Elaine, John, you know, about the importance of asking staff what they need rather than assuming we know. And it reflects Caroline's earlier thoughts on seeing the person in front of you and I suppose listening and connecting with what they are saying.
Yeah, Mary, it reminds me of the principle from quality improvement about going to the people who do the work, listening to them and understanding what it is that they know.
So our next conversation is with Dr. Leonard Douglas, who is a consultant psychiatrist at St. Vincent's University Hospital. Leonard talks about Ballant groups, which are purposeful, regular meetings amongst a group of clinicians. There is a trained facilitator and they allow discussion of any topic that arises outside of usual clinical encounters. Leonard starts by explaining to us how a Ballant group works.
Between 6 and 10 people sitting in a room, and someone's invited to discuss a case that they saw that week that they found challenging, intriguing. They got too involved. They were confused. What the hell went on? Those sort of interactions that aren't just a straightforward transaction between, patient comes to healthcare staff looking for something, healthcare staff gives it to them, everyone walks off happy. I think it helps with keeping curiosity rather than cynicism, and keeping interest and thinking about what else could be going on, particularly with tricky scenarios or not.
And you've talked about some of the benefits there. And do you have people report it to you, or do you feel there are broader benefits that having those type of group discussions, what they can bring?
Well, I suppose it is that, and then it's sitting together with people. But you can sit together with people drinking tea, and that's great as well. And when you actually talk about staff engagement, or staff being content, or staff being able to deal with the next challenge, a lot of it's about just being friendly with people talking to you, knowing each other's names, actually feeling like you can work with the people you can work with. But if that's in place, well, this is an addition. I don't think it fixes that. It doesn't set out to fix broken systems, or even the doctors who are presenting a case, they're told it's not group psychotherapy, or it's not to sort out the doctor. I've done it with a few different groups outside of psychiatry who wouldn't have just got into it through their training. Usually what you then is you're putting it out, and the people who come are the interested ones. And people, it's very normal. There's nothing kind of psychobabbly about it. Like, they're called balance groups, actually. I haven't mentioned that, but they were devised by a GP and his psychotherapist, or a man and a woman. One was a GP, one was a psychotherapist, and they were for GPs who were seeing the same thing repeated interactions with not a lot of outside, reflection. So it was designed for that sort of group. So it's very suitable for talking about any interaction that goes on between healthcare staff. The challenges are to make sure everyone in the group is of a similar, they see each other as peers, that there's no superiors, or because if you're going to talk about stuff that's tricky, you have to at some level be a little bit open about going, geez, I think I made a mess of it, or I was too annoyed with that person, or I'm too fond of them, or whatever. And if a manager's there, it's not great. So they're the challenges about getting the people in the group right. That wouldn't be a problem in psychiatry because it's set up for BSDs and HSDs. You want to make sure someone presenting the case doesn't get attacked by the group. Attacked as in interrogated to the end. Doctors and healthcare staff are very good at, I wouldn't have done it that way. All this sort of thinking or talking, even though they wouldn't say it to each other, there'd be questions. So you're trying to make sure the presenter just presents the bones of it, and the group actually does all the work. Usually in a lot of things, the person presenting the case has to do all the work, but actually in this case, they're the lucky one. They present the bones of it and get to hear lots of opinions, so it's the reverse. So you'd be saying that at the very start, you'd be explicit about these things, that, the presenter's on the nice road here, and the work is to be done by everyone else, so it kind of switches around. And you want to confidentiality is a big thing as well, so you make sure that, what's talked about in the group, you don't go out afterwards talking about it to each other about, did you see what that person did, or wouldn't have done it that way, or even though you're not going into the details of how things were managed. We're trying to steer people out of that, because we're good at doing that anyhow, we don't need that. But I think making sure people feel safe, and that it's not going to be talked about afterwards unless the person presenting talks to someone about it.
Do you see benefits in that? Have you seen over the years what benefits arise out of that?
It's hard to know, because it's hard for me to say, because it's always been happening. Do you know? So I can only talk about the other groups where you were doing it in a department where maybe it hasn't been happening. And then it just seems like it's a sigh of relief maybe. Oh, nice to have something like this. This is different. It's like having a new local coffee shop to go to that's really nice, and you happen to meet people in it, and it's all cozy and safe or comfortable. So I think there's that's different to most other sitting around the group as a healthcare professional. I think that would be the value of it. And if you know people in that way, it's a little bit nicer. It's the regularity of them, the difference between them and other group support things, whether it's people going doing stuff together or, you know, having different types of meetings. It talks about patients and doctors and kind of keeps you grounded in that rather than talking about systems. Because there can be a feeling that if you just sort out the system, everything's fine, but actually doctor-patient relationships are the thing that this really focuses on, and everything else around it. But if you're talking about healthcare, I suppose doctors or healthcare professionals and patients should be the core of it, and if they're the challenge, it's nice to tease them out, and then the issues around them, which might be how you are or how the patient is in that interaction, or the system that's supporting that interaction can be a problem that can come up. But too often a lot of other ones are a bit more generic, a bit more talking about an issue that we'll analyse and intellectualise, and that's of all real value. And you look at different ways of managing systems and improving systems, it's all vital because it supports people to look after their patients. But at the end of the day, it's that relationship that, if you really think about it, can be the challenge in your individual work if you're working as a clinician.
So that was Leonard Douglas talking about Ballon groups, which I have to say, John, were completely new to me.
I'm familiar, Mary, with a lot of what Leonard was saying there, because I've been a member of a Ballon group in Temple Street myself now for a number of years. And it does provide space for us as a group of clinicians to engage together and to process some of the challenges of work. And like Leonard says, it's not the usual clinical challenges, but the emotional challenges and stresses that we often don't get to talk about. And in Temple Street, it's not mandatory for us to do this, but we all see the value of it. But despite that, it can be really hard to find the time and space to do this. And I think we have to really try hard to create a culture that allows us the time to do this and that recognises the value of groups like Ballon.
Yeah, it seems, John, listening to yourself and Leonard, that trust within such groups is very important, so people feel able and I suppose safe to speak up and share their challenges and experiences.
Absolutely, and I think this is where leadership within organisations plays a key role. And there's strong evidence that enabling and empowering staff needs leadership that can come from anywhere within the organisation. And to that point, I spoke with Lucy Nugent, who is the CEO of Tala University Hospital. And many people say that leadership is recognising that it's all about the people. Well, I started my conversation with Lucy by asking her, is it?
Absolutely, we're a people business. Our actual vision statement is people caring for people to live better lives. And everyone assumes that's about patients, which it is, but it's also about staff. You know, we spend the majority of our waking hours in work, and it's really important that people feel valued and are happy to come to work. It's down to culture of an organisation. And I mean, a lot's been talked about the pandemic. One of my learnings, I think, was we always used to say, and I used to always say, you know, patients are number one, staff come a very close second. Actually, the pandemic flipped it initially because I think we're all concerned about how can we protect our staff, number one, from getting COVID, but secondly, the huge sacrifices and I suppose fear that people had. I would like to think that staff felt supported. For example, as a team, like as the executive management team, we took a collective responsibility. For example, my director of finance at one stage drove to Tullamore to get PPE because we were running low. That's the kind of, I suppose, culture of we're in it together. There's a very team focus, not just at an executive level, but throughout the organisation. For example, I meet every new permanent consultant, and the first thing I say is I thank you for coming to work here. Simply speaking, I go to the staff inductions, they're held every month, and I'm the first speaker, and the first thing I say is thank you for choosing to work here, because I think that's really important to acknowledge that there's a balance in an employer and employee relationship. I think it's really important to say thank you. We don't say it enough, and I do struggle to make it meaningful, and I think it's really important to celebrate small successes, and obviously we are very conscious of money, but for example, having the 99 ice creams Mr. Whippy van a couple of times a year, I can justify the cost of that because I think you get it back tenfold. Similarly speaking, we celebrate our staff every year with our Athinyaa University Hospital Heroes Awards, and they're nominated by their peers, by patients, by the public, and then the CEO Awards. And for example, the CEO Award could be something I have, like for example, one of our recipients the year before last was Wendy, one of our social workers, and she came in with a broken arm to finish a case because she knew it was important for that family. That's going above and beyond. You have to be accessible, and sometimes, I laugh. We have a very long corridor here in the hospital called the hospital street, and if I'm planning on going down it, I have to leave 10 minutes earlier from where my meeting is, because I'm going to get stopped, and I absolutely want that.
It's great to hear, John, how important staff and staff engagement is to leadership at Tallaght University Hospital. It's also lovely to hear how regularly Lucy gets to meet staff, whether, it's through the monthly induction meetings that she described or through the chance encounters on Hospital Street. During your conversation, did you ask her about any other insights on how they maintain focus on staff?
Yeah, I did, Mary. I asked her about what practices they have to continually engage with staff, highlighting what's good and addressing, the challenges that they face every day.
One thing that our board of directors, we start our monthly meeting with is the patient stories. And there's a positive one and there's a not so positive one. And again, so we're very open about trying to keep that balance, because we don't get it right every time. But again, it's about celebrating like you. So, we do get letters of compliments in, and I always make sure that it's shared with the team, and they know it's come into the CEO office. If I get the chance, I might try and go down. Often I don't. But I think it's those. It's about acknowledging that feedback.
How do you keep going? Two years on now, nearly, and and all of the the complexities of COVID have evolved. We're now trying to respond to the the difficulties of what's built up, and waiting lists, and cyber attack, all those things that have mounted up, and yet we're asking staff for more again in terms of responding. How do you keep that kind of sense of hope and engagement going?
It's the optimist in me, but no. On a more serious note, I think COVID challenged us, absolutely, but my God, did some really positives come out of it. There's agility.
How do you get that balance right between agility and then the responsibility for safety, or for when things might go wrong? How do you strike that balance, and where do you strike that balance?
Again, it goes back to I'm not one person alone. I have colleagues that I can draw their expertise into a decision, and I think that's really people often say, "What's your leadership style?" And it is very much a collaborative leadership style, except for when I have to make a decision. So maybe it's an adaptive leadership style, and I think you need that balance. But again, there's a lot of talented people in the health service. It's about trying to create space, both head space and physical space, to actually say, how can we keep moving forward?
So as we come to almost the end of this episode, one of a number we're bringing you in collaboration with our colleagues in Northern Ireland, we thought it might be interesting to hear the experience of consultant endocrinologist Dr. Athinyaa Shiraviraj, who is the clinical lead for engaging staff in improvement. She uses a QI approach called the Big Room. Athinyaa starts her conversation with me by sharing what staff engagement means to her.
For me, staff engagement is about, so if as a person working in an organisation, if I get out of bed and I come to work, and I'm coming to work as a whole, as fully myself, with doing the job that I have to do, but always keeping an eye out for how could I do this better? Am I and always constantly monitoring myself, my peers, my colleagues, and the service users, and say, is my service user, is the person who is using my service getting what they need? Is the service delivering what it's supposed to? And in doing so, am I and my peers and my colleagues, are we able to have a fulfillment in our jobs? Oh, is there joy at work, or are we all going home stressed, or even coming into work stressed? So if there's a constant congruence with who I am and who I am at work, that means I'm an engaged member of staff. It's not just whether I have a voice to share, or I have a title that says I'm an engagement officer or a leader or an improver. It's not about the title. It's about my mindset of how I turn up at work. Do I turn up at work as my whole self, or do I always find that I have to filter what I say and refine what I say because the system is not going to be really accepting of that? Now, that's going to be a really mature system, isn't it? It's going to be a really mature, adaptable, open, learning, safe system that ensures that not just one or two people who will always find their way of saying things, but every last one of us could feel, oh, I have an idea, I'm going to voice this, and that'll be taken up. So the big room is essentially not necessarily by physical dimensions a big room, but it's a room full of people with big ambitions and big heart. And by that, what I mean is a big room is an open platform. It could be virtual, it could be real. It is an opportunity for varied individuals to come together, all wrapping around a common goal. So the individuals could be healthcare users. It could be people who've currently experiencing healthcare or previously experienced healthcare, or we've even had sometimes individuals who are yet to experience that particular pathway. But we certainly also, at an equal importance, have involvement from staff groups, both clinical and non-clinical. And the way it works is that we pick up care pathway. So the one I'm very familiar with is the diabetes and pregnancy pathway. And we involve all women who are currently or previously had diabetes in pregnancy and invite them into the big room. And equally, we have an open invitation to all staff members working in the organisation who have either directly or indirectly involved in her care. So obviously it has obstetricians and midwives and diabetes consultants and doctors and dietitians and nurses, but it also has administrators, clerical staff, managers, finance directors have dropped in. The chief executive has dropped in occasionally. We've had kitchen staff. We've had porters. We've had the breastfeeding midwife. We've had parent craft educators. We've had community health visitors. So it's just this really rich, diverse group of people. And they're not bringing only their clinical self or their individual self. So one of our patients one of the women who had diabetes in pregnancy, she helped design she's an artist. And she helped us design a lot of the information leaflets using her artistic approach. I ended up creating cartoon videos, which was completely out there. It was nothing to do with being a diabetes doctor, but it became a place where we were doing really serious work. We're having a lot of fun with it. It was a distressing scenario because the clinics were overrun, everybody was unhappy, patients were waiting very long. And when we started working with it and we started meeting regularly, there was a lot of respect in the room, and it was facilitated by coaching methodology. And I think that's the real USP of the Flow Coaching Academy. It takes two coaches, one an improvement coach and the other is a clinical coach. And a clinical coach is somebody who's got credibility and presence within the team. And in this case, that was me. And the other is an improvement coach, who is Karen. And the two of us work together to really to be there and be present. We were not leading the room. We were not fostering the room, nothing of that sort. We were there just as coaches. We were there to let the conversations happen, to maybe nudge the conversations occasionally, and very commonly to ask questions. And the decision making, the ideas, the decision on what should happen, what should not happen. It was all very much owned by the people. And I think it's the owned. It wasn't a improvement that was put upon somebody. It was owned by the people. So there was a huge degree of autonomy. And I think it was the first time people felt, okay. I remember one of our diabetes nurses saying, oh, sure, I've seen all these fads come and go. This is just another thing. We'll have 6 meetings, we'll have 10 meetings, and then it'll be done. 3 years later, we're still going, and she's there, and she's making the change. Now, that is an engaged person, right? And the main thing was autonomy and authenticity. Everybody brings their authentic self to that conversation, and their autonomy is respected. And really, that, for me, is the kernel of what we need to do. And coaching helped us make sure that could happen.
So how have you found over the last 3 years that the big room has supported staff engagement in the Western Trust?
When we started, it was about 2018, June, July was when we did a lot of preface work. So it was about meeting people, because you have to remember, everybody was, this is even before all COVID, there was a lot of pressures, healthcare system across the world are working under pressure. It's the job we signed up for, but there's a lot of pressure, and a lot of people didn't want to really stop and think about change because they were busy working already. But that was the first thing. It was about meeting people, listening to concerns, ideas, gripes, whinging. There was a lot of that. So we really needed to work through that, and it took a lot of time. But then what happened was there was a shift in the system. People started realizing, okay, it's clear we need to make change, and there's nobody coming over the horizon to make this change for us. And then the penny dropped. I am the system. I am going to make the change. And when each one started saying that, the I became we, with still respect for each of the I's present in the room. And then we started making the changes. Now, it was slow going, but everybody was quite comfortable with that by that point. No, we don't want to rush. We want these changes to stick. If these were easy problems, they'd be sorted by now. We're dealing with wicked problems. It's going to take time. We want to get this right. So there was a lot of nitty-gritty working through. So it took us about a year and a half to really get on top of problems. It took us 6 months, 8 months to understand the problem or understand the system and develop enough knowledge across the group about it. And then it took us another 6 months or so to innovate and think about how we might do things differently. And during that time, the whole team, along with the patients who are experiencing the service, went through a major change, and they started thinking outside of the box, going from fixed, this is what we can do. Oh, we can't do that. We can't do that. They started asking the question, why can we not do this? Why do we have to do this? Why not this? So it started really unleashing a lot of innovation and creativity, which was already present. It was like literally taking, phosphorus out of water. There was nothing else that needed to be done. People just needed to unlearn the bad the habits. I can't even call them bad. Unlearn the system trust habits. And then they started being really creative, being very highly innovative, and then started making the changes. And then, sure, the feedback came back. The data came back to say, here's how things are changing. So by the end of about 12 months, 18 months, pretty much everybody who participated, and there was about a dozen people who always turned up and engaged in the big room because they could see the difference that it made in their day-to-day life, but also got really excited about the change that was happening, the connections, the human connections that was happening. And we used improvement methodology. They understood that. They started using that not just in the big room, but outside in their work. They started monitoring data, and then they found the next big leap was, look at what we've done. That pride in work, pride in the outcomes. And then we had the opportunity to showcase it in a couple of places, and that really boosted them.
Dr. Athinyaa Shiraviraj there, describing how she and her team at Altna Galvin have used the big room quality improvement concept to support people to come together and to collectively work and innovate as a team focusing on improving care.
I think listening to Athinyaa, John, you can really feel the energy that they're creating in that big room together. However, speaking of energy, I think that's probably it from us for this episode.
I think so, Mary. Remember, you can listen back to this and other episodes wherever you get your podcasts, and please subscribe to get notifications when new episodes are added.